The question is, without chemotherapy, what can be done?
So the question really is, can we do transplant without chemotherapy? And is Jacob here? No. I'm not a bone marrow transplant expert, but my understanding is whenever you use any donor cells from another individual, that you need some level of conditioning and then immunosuppression afterwards. With the last two approaches, the patient's own cells, the induced pluripotent cells, the goal there is because the cells came from that patient initially, they should be able to go back into that patient without too much trouble because they're identical to the patient's own cells except for the fact that we've either ourselves corrected the mutation or that their own cells have corrected. In that case, my understanding is that you still need a little bit of chemotherapy to just open up some space in the bone marrow. But you don't need the immunosuppression, the drugs that come afterwards, to prevent from rejecting those cells. In theory, you shouldn't need that because they came from the patient themselves. So my understanding is that when we use our own cells, the autologous cells in IPS, that the drug regimen should be much less. I think it's important to emphasize, though, these are still very, very early days in this work. And I think there are lots of exciting things going on in the lab, but I don't think there's any trial yet in any disease using induced pluripotent cells. So this is really something out there for us in the future. But the theory would be that no, you shouldn't need as much drugs as we do right now for unrelated donor cells. For IPS cells, we're doing it, Jacob's doing it, Dennis Roop is doing it. There's lots of people doing it in the different types of EB. Maybe we can provide resources either through DebRA on their website. Oh, you're closest to New York then. So, yeah, absolutely. Kids here.
Thank you. We can take one more question now. Yes.
Anybody, do you think there's a difference in success with bone marrow if the donor is HLA matched but heterozygote or unaffected? Do you think that makes a difference?
So Dr. Lucky's question is, if the donor happens to be a carrier, a sibling, is there a difference in either the success of the transplant, I guess, or in how much protein is made? I don't know the series up to date in Minnesota, but my guess is it's probably too early to even say that. I think the feeling is that if a sibling who's a carrier is a perfect match, that's a better choice for the transplant donor than an unrelated person who's a lesser match but has two type 7 collagen genes intact. So at least my experience has been that they prefer to go with a sibling donor even if they are a carrier, or a haploparent donor who would also be a carrier.